Pharmacokinetics, Metabolism and Excretion. Chapter 2. Drug metabolism is a crucial pharmacokinetic process that modifies drugs to facilitate their excretion. It can result in toxic drug getting converted into non-toxic metabolite, prodrug, e.g. valacyclovir, getting converted into active drug, acyclovir, active drug getting converted into inactive drug, which then gets excreted, phase 1 of drug metabolism. How body chemically modifies a drug. Mostly uses the enzymes to change the structure of the drug, like CYP450 enzymes, especially CYP3A4, CYP2D6, and this occurs mainly in the liver. Changes the drug by oxidation, most common, reduction, hydrolysis. Example: convert a prodrug into its active form, e.g. valacyclovir to acyclovir. Inactivate a drug, active drug to inactive metabolite. Detoxify a harmful substance. Factors affecting phase 1 metabolism: CYP2D6 genetic polymorphism, rapid metabolizers. This increases the enzyme activity. Active drug rapidly converted to inactive metabolite. It decreases the active drug concentration and decreases the therapeutic effect. So, this may require higher dosing. Slow metabolizers. This decreases the enzyme activity. Active drug persists longer in the system, thus increasing the risk of drug toxicity. Example: codeine in infants, slow metabolizers, can cause excessive sedation, respiratory depression due to high codeine concentration. CYP450 inducers. This increases the enzyme activity, which makes the drug metabolized faster and converts the active drug into inactive form rapidly. Effect on warfarin, an anticoagulant. Enhanced metabolism will decrease the warfarin levels and increases the risk of clot formation. Common inducers are rifampin, phenytoin, phenobarbital, PHB, carbamazepine, depression. Due to high codeine concentration CYP450 inhibitors. This decreases the enzyme activity by slowing the drug metabolism where active drug remains longer in circulation. Effect on warfarin. Accumulation of warfarin will increase the risk of bleeding. Common inhibitors: azoles, e.g. ketoconazole, erythromycin, ritonavir, omeprazole, liver disease, e.g. cirrhosis. This reduces the amount and efficacy of CYP450 enzymes, which decreases the metabolism and increases the active drug concentration, increasing the toxicity risk. Phase 2 of drug metabolism. The second step, where the body adds a chemical group to the drug, or its phase 1 metabolite, to make it even more water-soluble. Key features: involves conjugation reactions and uses transferase enzymes. Common groups added are glucuronic acid, glucuronidation, sulfate, sulfation, methyl group, methylation, acetyl group, acetylation, glutathione. It results in highly polar, inactive, and non-toxic compounds that are ready to be excreted. Factors affecting phase 2 metabolism: genetic polymorphism. Some people have slower or faster activity of phase 2 enzymes. Example: slow acetylators, common in some populations. Slower drug clearance. Increased risk of toxicity, e.g. with isoniazid. Age. Newborns and elderly may have immature or reduced enzyme activity, especially for glucuronidation, e.g. chloramphenicol toxicity in newborns, gray baby syndrome. Liver disease. Like phase 1, liver damage can reduce phase 2 enzyme levels, less conjugation, drug accumulation, and toxicity. Nutritional status. Some conjugation reactions, e.g. glutathione conjugation, need nutrients or cofactors like glutathione, S-adenosyl methionine. Acetyl-CoA malnutrition or deficiencies can impair conjugation. Drug interactions. Some drugs may compete for the same transferase enzyme or inhibit it. This is the quick recap of both phase 1 and phase 2 reactions. Drug excretion is a key pharmacokinetic process that removes drugs and their metabolites from the body. It can result in unchanged drug excretion, e.g., aminoglycosides, lithium, metabolized drug excretion, e.g., morphine glucuronide in bile, urine, volatile drug excretion via lungs, e.g., nitrous oxide, ethanol, poorly absorbed drug, fecal excretion, e.g., neomycin, primary routes of drug excretion, renal, urine, most important drugs and metabolites filtered, secreted, or reabsorbed in kidneys. Polar, water-soluble drugs, low lipid solubility, are mainly excreted this way. Examples: aminoglycosides, digoxin, lithium, hepatobiliary, GI, bile, feces. Larger, polar compounds may be secreted into bile by liver transporters. Some drugs undergo enterohepatic circulation. Drug excreted into bile, intestine, reabsorbed, prolongs half-life. Examples: morphine, steroid hormones, chloramphenicol, rifampicin, pulmonary, lungs. Excretion of volatile gases and anesthetics depends on solubility and ventilation. Examples: nitrous oxide, ethanol, halothane. Fecal excretion, drugs not absorbed from GI or secreted into intestines, sometimes due to active secretion from GI mucosa. Examples: neomycin, poorly absorbed, unabsorbed bile-excreted drugs. Other minor routes: sweat, saliva, tears, breast milk. Usually these are clinically unimportant, but breast milk excretion matters in lactating mothers. Lipid-soluble weak bases accumulate. Factors affecting drug excretion: filtration, at glomerulus, GFR, glomerular filtration rate. In AKI or CKD, GFR is reduced, leading to less drug filtration and more drug stays in blood, which then increases the risk of toxicity. Example: digoxin, dose must be reduced in CKD. Protein binding, albumin, only free drug gets filtered. If drug is highly protein-bound, less drug filtered, stays in blood, increases the toxicity. Example: phenytoin, warfarin, both highly albumin-bound. Secretion, at proximal tubule. Some drugs move from peritubular capillaries to the kidney tubular cells, from there to lumen, and moves out through urine. This may depend on solubility and concentration gradient, but many need transporters. Drug 1. Polar, water-soluble. Large molecules. Cannot cross membranes freely. Need active transport. Transporters: OAT, organic anion transporter, for acidic drugs; OCT, organic cation transporter, ARO, for basic drugs. Requires energy. ATP, ARO can move drug against concentration gradient. Examples: penicillin, secreted via OAT. Methotrexate, OAT substrate. Drug interactions: cimetidine or trimethoprim, sulfamethoxazole, TMP-SMX, can block OAT-OCT, which leads to reduced secretion. Drug stays in blood for long and cause toxicity. Drug 2. Non-polar, lipid-soluble small molecules can cross membranes easily, move by passive diffusion. Do not need energy or transporters. If concentration is high in blood and low in tubule, drug diffuses freely. Examples: barbiturates, benzodiazepines, reabsorption at distal convoluted tubule. After filtration, drug moves through tubule. At DCT, drugs may move back into blood, reabsorbed. Depends on the molecular size, should be small. Polarity, the drug should be nonpolar to be reabsorbed more. Lipid solubility, it should be hydrophobic drug, which cross the membranes easily, reabsorbed. Excretion. Examples: lipid-soluble drugs like barbiturates are reabsorbed. Many drugs are metabolized in liver, polar metabolites, so they cannot be reabsorbed, excreted in urine. Modifying excretion, in overdose, urine pH trapping. In overdose, we can change urine pH to prevent reabsorption and increase excretion. Weak acids, e.g., phenobarbital, aspirin. Equation: HA H plus A minus. If we alkalinize urine, give NaHCO3, reaction shifts right, more drug becomes polar, cannot cross membranes, trapped in urine, excreted. Clinical use: In aspirin/phenobarbital overdose, give sodium bicarbonate to enhance excretion. Weak bases, e.g., amphetamines. Equation: BH plus equals B plus H plus. If we acidify urine, give NH4Cl. More drug becomes polar, cannot cross membranes, trapped in urine, excreted. Clinical use: in amphetamine overdose, give ammonium chloride to acidify urine and enhance excretion. Drug clearance and elimination kinetics. Clearance, Cl. Definition: clearance is the volume of plasma cleared of drug per unit time, or mathematically, Cl equals rate of elimination, divided by plasma concentration. Formula with half-life: Cl equals Vd times 0.693 divided by T1/2, where Vd equals volume of distribution, T1/2 equals half-life. Components of clearance: Cl hepatic plus Cl renal equals Cl total. If liver or kidney function is impaired, it decreases the clearance, drug accumulates, and toxicity levels increases. Relation with half-life: long T1/2, low clearance, drug stays longer in body. Short T1/2 arrow, high clearance, drug removed quickly. Clearance is proportional to 1/T to the power of 1/2. Elimination equals metabolism plus excretion. Drugs are eliminated by metabolism. Liver makes drugs more polar for excretion and excretion, kidneys, bile, lungs, etc. Elimination kinetics. First-order kinetics. Most drugs. Features: T1/2 is constant, a constant fraction of drug eliminated per unit time. Rate of elimination is proportional to drug concentration. Higher concentration leads to faster elimination. Exponential decline in drug levels. Approximately 95% of a drug is eliminated after 4 to 5 half-lives. Examples: almost all drugs at therapeutic levels. Zero-order kinetics. Capacity-limited saturated. Features: T1/2 is variable, depends on concentration. A constant amount of drug is eliminated per unit time, e.g., 25 milligrams per hour. Rate of elimination does not increase with concentration, saturation of enzymes. Linear decline in drug levels. Drug dose, risk of toxicity. Examples: phenytoin ethanol, alcohol, aspirin, at high doses. Steady state, CSS. Definition: when rate of drug administration equals rate of elimination, achieved after 4 to 5 half-lives in first-order kinetics. It is important for maintenance dosing and chronic therapies. Clearance equals capacity of body to remove drug, depends on liver plus kidney. First order equals most drugs, predictable elimination. Zero order equals enzyme saturation, fixed amount removed, higher toxicity risk.